Can you hear me well? Yes. I want to thank you very much for that excellent opportunity to take part in this very nice event and to present our work in front of such a diverse audience. I'm very excited and glad to be here. So I'm going to talk to you about social cognition in relation to a disorder that one would probably not spontaneously associate with it. But I'm going to try and convince you that this is a line of work that actually matters a great deal to that specific condition. And I'm going to give you a very brief overview of some of the main findings of that emerging literature, talk in a bit more detail about the studies that we have conducted on our own in the past few years in order to contribute to it. And then I'm going to mention what we consider to be interesting perspectives in order to further move the fields forward. And my hope is that this is also some transdiagnostic relevance. But first of all, some basic introductory facts about alcohol use disorder, just to give a broad sense of how much of a problem it actually poses. So it's currently one of the most prevalent psychiatric disorders. 1 in 20 European adults are affected by it, and it's quite a significant source of both morbidity and mortality. It plays a causal role in over 200 distinct diseases, including cardiovascular diseases, liver diseases, and several forms of cancer. And people with an alcohol use disorder die on average 20 years earlier than those who do not. So it's quite a big deal. In addition to that, 1 in 3 people at least will report that they have suffered some sort of harm in the past year due to others. Excessive drinking and alcohol use disorder, of course, generates huge costs, huge economic costs to society. So all of that to say that alcohol use disorder is frequent and highly damaging. It takes a significant toll on affected individuals themselves, people around them, but also society at large. And for this reason, not me, but the World Health Organization considers it's currently one of the most pressing public health issues there is. So it's quite important because of that we have available effective ways to reach people in need of treatments and to effectively alleviate their symptoms. And currently we're far from there. The vast majority of people do not access any form of professional treatment. Among those who do, 1 in 4 will interrupt their treatment before it is completed. And among those who benefit from treatments, 60% will relapse in the first couple of months after their intervention. So this is quite a concerning situation that we have to face. And in this context, neuropsychological research has really imposed itself as one important way to tackle this issue by improving our understanding of the basic psychological alterations that are associated with AUD, but that also contribute to its maintenance so that we can adapt and improve the way we approach this disorder accordingly. And it already has started to significantly improve our understanding of it, and notably through 2 main lines of findings. The first is that alcohol use disorder is linked with biases in the processing of alcohol cues. So, for example, patients tend to pay more attention to alcohol in their environment. They also tend to remember alcohol-related events better than non-alcohol-related events. So that is the first line of important neuropsychological findings. The second is that AUD is also associated with massive impairments in high-order cognitive functioning, including the ability to encode, but also to recall episodic information. Really, the most prototypical finding there is that AUD comes with pronounced deficits in the ability to inhibit prepotent motor, but also cognitive responses. So they show deficits in what we call cognitive control. And these 2 line findings have given rise to currently prevailing neuropsychological models, according to which AUD is caused by that imbalance between, on the one hand, an increased processing of alcohol signals, which increases individuals' desire to consume, and on the other hand, that reduced cognitive control that prevents them from overcoming those urges. And these models have gained quite some traction over the past years, and they've really led to the development of innovative therapeutic tools. There are some programs available that aim to train participants' attention away from alcohol and toward healthier alternatives. or some programs aimed at rehabilitating cognitive impairments through computerized exercise. And some of those tools have shown signs of usefulness. Unfortunately, there's also a growing literature suggesting that these models are limited. The associations between processes in those models and important clinical outcomes, disease severity, treatment completion, or relapse, for instance, are inconsistent and oftentimes relatively modest. And so are the effects of treatments that target those processes. This is just one example. This is a graph from the largest clinical trial to date, which looked at the efficacy of substance bias modification training in alcohol use disorder. And what this study shows quite clearly is that among people who benefit from that intervention, which are here in blue, people abstain more, significantly more from alcohol in the first couple of months after the intervention. And this is immensely valuable already. But we can also see that that difference is relatively small and that it fades away over time, such that even among those people who benefit from the intervention, after 1 year, 80% have relapsed. So what this clearly shows is that, yes, current models are useful, but they are likely not to tell enough of the story. And our take specifically is that although these models shed light on important processes for sort of directly and proximally understanding the loss of control over alcohol consumption that is key to the diagnosis, they fail to account for an important aspect. And to us, that aspect is that very often, this reduced control over consumption occurs within the context of massive interpersonal problems. Alcohol use disorder is linked with increased aggressiveness, difficulties adhering to social rules, intrusiveness, loss of assertiveness, social discomfort, and isolation. And of course, all these things can cause significant distress to patients themselves and their entourage. And there's very good reason to believe that these interpersonal problems are not mere consequences or byproducts or epiphenomena of alcohol use disorder, but that they actually actively contribute to its maintenance. This is just one illustration. This is a recent study conducted in a very large sample and assessing a very large array of variables thought to be of more or less interest to alcohol use disorder. And what those people did was use a statistical approach called causal discovery modeling, which basically allows highlighting variables that have a high likelihood of being causally involved in a construct of interest. And what the study shows quite clearly is that interpersonal factors appear quite prominently among those causal variables. But further and perhaps more concrete evidence for their active role comes from studies showing that interpersonal factors, for instance, conflicts with others, external social pressures, or the desire to be able to have a good time with others, rank among the most frequently reported reasons for relapse. And this is far from being an isolated finding. It has been repeated several times and already shown some 20 years ago. And what's quite interesting is that this is true regardless of the duration of abstinence, but this is particularly true after people have abstained for a long time. So put differently, very often, the very reason people relapse, so the very reason alcohol use disorder is maintained in time, is interpersonal in nature. And these interpersonal factors continue to be a problem even long after alcohol itself has exited the system. So to us, what this suggests is that it's quite important to take into account interpersonal problems and alcohol use disorder. They independently contribute to important clinical outcomes. And if we agree with this view, we must also agree that our current models are limited and that they should be extended in order to be able to also account for those interpersonal problems. And this is really when AUD research has started to take an interest in social cognition. And what this literature has shown over the past 10 to 15 years, where it has really started to bloom, is that alcohol use disorder is associated with robust, meta-analytically robust, and quite large impairments in two key social cognitive abilities. First is emotion recognition, so patients struggle to identify the social signals that are conveyed by the emotional signals that are conveyed by facial expressions, and they also tend to perceive signs of social threats on those faces, even though these are objectively absent. And the second component found to be highly impaired is theory of mind, which is perhaps the higher order ability to reason about and infer others' complex mental states, their desires, their beliefs, their intentions. And this had notably been shown using a task that was developed by one of tomorrow's keynote speakers, which is basically a movie task of interacting people. And sometimes the task is stopped and people are queried about the mental states of selected characters. And quite importantly, studies have not only shown that AUD is linked to marked impairments in social cognition, they've also shown that these impairments predict increased interpersonal problems experienced in real life, but also important clinical outcomes such as treatment dropouts and relapse. And there's longitudinal evidence for this. So it is suggested that social cognition research seems to be quite a relevant domain in order to extend our neuropsychological models. And then appears to be well worth delving a bit deeper into it, which is what we tried to do over the past couple of years during my PhD. And we did so in mainly 3 ways, each of which still represents an important perspective, and each of which was aimed at addressing what we thought was an important limitation at the time. First thing we tried to do is expand the field scope. So as I mentioned, there have been quite a few studies looking at emotion recognition and theory of minds, which are important components of social cognition, but there are others. And the reason these other components have not been looked at is simply because the field lacked anchorage within the clear framework specifying what these components might be. But such frameworks exist, and perhaps one of the most influential is the one proposed by Green and colleagues, initially within the context of schizophrenia, but this is a framework that has really come to guide social cognition research transdiagnostically. And what this framework suggests that in addition to those two, social perception and knowledge and attributional biases really constitute clinically relevant components. So we tried and had a look at those in alcohol use disorder. And the first we looked at was social perception and knowledge. It has 2 subcomponents: social perception, which is the ability to interpret not individuals' mental states, but social situations as wholes, and requires the ability to integrate those situations within their context, identify the roles that are currently being endorsed by people, but also the nature of their relationships. For example, in order to make sense of that picture here, one needs to realize that it takes place within the public transport, that people are customers of that public transport, and that they likely do not know each other very well. And the second component is social knowledge, which is the ability to identify the latent social rules, expectations, or norms that prevail in social situations. So we tried to assess that in alcohol use disorder patients and healthy controls using a task that was specifically developed for that purpose by French colleagues. And basically it shows a series of complex social pictures like this one. For each of the pictures, participants are asked to exhaustively describe the pictures, and they get described the social perception score that is higher the more people correctly refer to important elements of the context, people's roles, and the nature of their relationships or of their interaction. And as a second question, we simply asked them to pinpoint the social rule that was being illustrated. And what we found quite clearly here is that patients with an alcohol use disorder, here in red, perform much more poorly than healthy controls at both tasks. And quite importantly, this persisted after controlling with a non-social ability to list as many elements as possible on those pictures. So it's not really only about general attention or fluency. So this was the first evidence that social cognition deficits or difficulties extend beyond the first 2. And then we looked at attributional biases. So these are tendencies to explain situations in certain ways rather than others. These are biases and causal explanations. And in psychopathology, there is a specific interest for what we call hostile attributional biases, which is the tendency to ascribe the causes of ambiguous situations to others' hostile or malevolent intentions rather than to more neutral. And to assess this, we used the tool that was most frequently employed at the time, which is the AIHQ. It provides a series of ambiguous written vignettes like this one, And participants are asked to provide a written description for those vignettes, and then they are then coded by external raters. What we found here was that patients' explanations much more often refer to others' hostility than explanations of healthy control. So this is evidence for a hostile attributional bias in alcohol use disorder. And we thought that this might be particularly detrimental to interpersonal relationships and clinical outcomes. So we tried to replicate that finding. And we did that in a completely independent, larger sample and using a different measure that overcomes some of the limitations of the IHQ, which is the word sentence association paradigm. Basically, you show a series of short, ambiguous sentences, such as this one. Sometimes they're presented in association with a hostile, and sometimes with a benign word. And the idea is that participants have to rate as fast as possible to what extent the word and the sentence relate. And what we found here was that when the words were hostile, patients' ratings were much higher than healthy controls, which again provides evidence of a hostile attributional bias. And again, or not again, but what we also found was that there was no group difference for benign words, meaning that the group difference we observed earlier can indeed be more confidently ascribed to hostile attributional biases, not diminished benign attributions. All right, so if we summarize that first line of findings, what we did was provide evidence that social cognitive difficulties and alcohol use disorder are not restricted to emotion recognition and theory of mind, but seem to be more widespread and extend to other clinically relevant components. This really shows the importance of integrating the field within a framework. It offers us a more comprehensive understanding of the scope of patients' difficulties, and also from a neuropsychological perspective, it allows us to better account for the number and diversity of interpersonal problems that we can observe in AUD. And we think that describing those difficulties alone already carries some interesting clinical implications. And it is quite easy to see how difficulties in social perception and knowledge or hostile attributional biases can lead to tensions in clinical settings, and notably could threaten the therapeutic relationship, which is pivotal to both treatment completion and treatment success, and how simply informing clinicians about those difficulties can help them implement very easy adjustments in their clinical routine in order to try and minimize the impact of those difficulties. So already by describing difficulty, we can start to tackle some of the problems we highlighted before. But of course, ultimately, we want to be able to do more than simply describe difficulties. Ideally, we would like to be able to do something about them. And in order to develop treatments that are both targeted and specific, we need to go beyond such a purely descriptive approach and try to identify what the basic and actionable mechanisms are that underpin those difficulties. And this is what we try to do in the second line of pre-registered studies. Now, in order to guide our investigations, we refer to a relatively simple and intuitive model of social information processing, according to which when we make social judgments, when we try, for example, to determine what that little boy's mental state is, we go through two main stages. First, there is an information extraction phase during which we basically align our attention to important information in the environment. And then there's a more interpretative stage during which we generate hypotheses based on what we extracted, but also based on information from within our own knowledge, our own previous experiences, in order to try and determine which of these hypotheses is most probable. So what we tried to do was see if alcohol use disorder could be related with alterations in processes that interfere with the normal extraction or interpretation of information. And in the first series of studies, we looked at how patients attend to social information. More specifically, in the first, we looked at how patients attend to faces, because faces, of course, are a primary source of social information. And this might especially be true in the context of emotion recognition. There are quite influential proposals suggesting that different emotional states map onto characteristic activations in facial muscles, primarily located around the mouth, nose, and eyes. Now, if these regions carry information, it's quite important that we attend to them. And to investigate this, we used an eye tracker. Basically, an eye tracker is an infrared camera that allows localizing participants' gaze on a computer screen. And we use that technology in order to precisely quantify participants' attention allocation to the mouth, nose, and eyes of facial expressions during an emotion recognition task. And what we found here was that patients, again here in red, did not differ from healthy controls in their attention to the mouth and nose, but they spend significantly less time attending to the eye region. Now, this is an interesting finding because the eyes are thought to carry critical information, notably for differentiating among negative expressions, which are particularly challenging to recognize in AUD. Now, in the second study, still looking at attention, we asked a different question, not whether AUD relates to reduced attention to objectively informative information, but whether they could show biases, different preferences in their attention to certain social signals. Specifically, given their hostile attributional biases, we thought that maybe they could attend to social threats more in their environment. And we investigated this using a modified version of a widely used soft growth task. Here we showed basically pairs of one neutral and one emotional facial expression. We included facial expressions of anger and disgust, which was how we operationalized social threats, but we also included sadness as a non-threatening but negative control, and also happy expressions just for exploratory purposes. And again, we used our good eye tracker in order to quantify participants' attention to each of those faces. And what we found here was contrary to our expectations. We found no reliable evidence that AUD was linked to biases in their attention to social threats. There was no group difference for anger and disgust. There was no difference either for sadness. However, we found some interesting exploratory evidence that patients with an alcohol use disorder lack the strong attentional bias for positive social information that was very clearly evident in healthy controls. This is also an interesting finding, and I'm going to go back to that a bit later. Okay, we then moved down the processing stream and looked at social memory, where alterations could not necessarily interfere with information extraction, but certainly with how that information is interpreted. Indeed, we leverage memories for our social cognitive judgments. And this is particularly true in ambiguous social situations, such as the one we discussed before, where in the absence of directly perceptible information, it is our previous experiences or knowledge derived thereof that will determine how that situation is interpreted. So we looked at social memory, and we tried to address two different but related questions. The first was, could AUD be linked with alterations in the initial encoding of new social information? And the second was, could it be linked to alterations in the ease with which they access already established social memories? But to say things a bit differently, if you think of your memory as a shelf, and the first study tackles what is initially put in that shelf, what is initially stored, and the second tackles what is most accessible to the little mountain that is drawn here on the right. To address the first question, we use a very simple memory recognition task. We showed participants a series of positive and negative dynamic facial expressions. And in the later phase that occurred a bit later, we simply showed those faces again, this time with a neutral facial expression. And we also showed them a couple of distractors, so people who were not shown before. And we asked participants to indicate whether or not they remembered seeing those people before. And what our results indicate is that, first of all, there was a tendency for patients to be poor at encoding faces in general, so regardless of valence, which is perfectly in line with studies of non-social episodic memory. But contrary to what we thought, there was no difference in the type of social information that was preferentially encoded. Both healthy controls and patients with an alcohol use disorder encoded happy faces much better than negative faces. And then to address our second question, are there alterations in the accessibility of existing social memories? We simply asked participants to remember and recall as many memories of positive but also negative social events as they could, and for each of the memory types within a time frame of 3 minutes. Our idea was that if certain memories are more accessible, people should be able to recall more of those. And what we found here was that there was no statistically significant difference in the amount of positive memories people were able to recall, but patients with an alcohol use disorder recalled much more negative ones. And we look at what this results in when we look within groups. We see that in healthy controls, there is a positive bias in accessibility to previous interpersonal memories, but the opposite is true in alcohol use disorder. If we go back to our shelf, what this study shows is that patients with an alcohol use disorder, just like healthy controls, appear to encode positive social information better than negative social information. However, negative social memories tend to be or appear to be much more accessible to patients. If we again try to summarize this, what we did here was shed light on very specific and actually malleable social information processing alterations that could constitute relevant candidate mechanisms for explaining some of the sociocognitive difficulties we talked about a bit earlier. Reduced attention to the eye region could, of course, contribute to poorer emotion recognition, but not only. Others' eyes also tell us something about their non-effective mental states, current focus of their attention, the interest they're having in our current conversation. And it can also, of course, be indicative of the level of intimacy that exists between people, for instance. Similarly, the reduced attention to positive social cues that we found exploratory evidence for could also lead patients to miss important information, particularly in complex social situations that comprise both positive and negative information, lead them to misinterpret those situations, but also view them as being more negative than they really are. And of course, this increased access to negative social memories could further fuel their hostile attributional biases, but also interfere with other components, especially when directly available sensory information is degraded or ambiguous. So what we have here is a very preliminary and here very simplified mechanistic model of sociocognitive difficulties and alcohol use disorder that will of course need to be replicated, extended, refined, and we're currently conducting some studies looking at cool new stuff. And in the end, it would have to be subjected to experimental manipulation in order to verify that indeed those mechanisms are causally involved in the sociocognitive difficulties. But we think this is an important start. All right, now the third thing that we think is important to do in order to move the field forward, and that we really just started scratching the surface of, is try to go beyond group comparisons and start addressing the question of heterogeneity. So what I've shown so far is evidence that on average, patients with an alcohol use disorder show difficulties in a series of sociocognitive abilities. And this is an important first step, but of course it hides a reality that is a bit more complex. So if we look here at individual data points, what we see is that, yes, of course, some people show quite pronounced impairments, but not all of them. And what we started to do was provide some statistical substantiation for those observations. Basically, we used single case analyzers called Crawford's t-test to show that, yes, only a subset of patients with an alcohol use disorder show clinically and statistically significant impairments in sociocognitive difficulties. And we've been able to show that in the context of emotion recognition, but also social perception and knowledge, and other research groups have come to very similar conclusions regarding theory of mind. Now, this is an important first step, but I think what we need to try and do now is to go beyond those dichotomous impairment, no impairment approaches, and maybe leverage more sophisticated data-driven approaches in order to shed light on the sociocognitive profiles that naturally can be observed in patients with an alcohol use disorder. This is, for example, a study that used cluster analyzers in order to show that in schizophrenia, which is widely considered to be a sociocognitive disorder, there are actually three distinct homogeneous profiles of people with different severity levels of sociocognitive impairments. And such approaches would, I think, be valuable in alcohol use disorder also. And of course, once we have characterized the different profiles of sociocognitive difficulties, a logical, important next step is to try to identify those variables that drive the heterogeneity. This is very important from a personalized medicine perspective, for example, where we want to be able to see who and under what circumstances shows sociocognitive deficits in order to see who might need treatment and who is likely to benefit from it. And there's some preliminary evidence that gender is an important factor in that regard. Colleagues from the University of Florida were, for example, able to show that women with an alcohol use disorder are particularly prone to show emotion recognition impairments. And we have recently been able to show that hostile attributional biases, which I talked to you about before, could actually selectively emerge in men with an alcohol use disorder. So this is preliminary evidence, and a lot of work is still needed in that direction. All right, before I leave you alone, I just want to mention a last perspective which we consider important. It may actually be the most important of all, because to some extent it will condition our ability to reach some of the objectives we discussed before in an effective way. And that is to maybe rethink how we conceptualize and measure social cognition in alcohol use disorder. The more we delved into the field, the more we realized how very confusing it is. Different researchers will use widely differing labels in order to refer to the exact same underlying construct, which of course makes the field difficult to read and difficult to access for newcomers or non-experts. And perhaps more preoccupying is the tendency for different studies or authors to claim to assess an ostensibly identical construct, but do so using widely differing measurement procedures. The problem is that all of those studies will come to similarly phrased conclusions, but all of these conclusions actually hide a very different reality. And each of those realities is very clinically important in alcohol use disorder, but they all call for very different intervention. So there's currently a strong mismatch between the labels that we use, the constructs they refer to, and the tools we use to measure them, which is a threat to developing a specific understanding of the difficulties presented by patients with alcohol use disorder, but is also a threat if we want to be able to translate research conclusions into concrete clinical interventions. So we really need to be more aware of this and try to do better in that regard. Then the tasks that we use themselves can be criticized, even those that are most widely employed, that are considered by some as gold standards. So for example, this is really the typical way in which we measure emotion recognition, but it can really be criticized. Is it really the wisest choice to show highly prototypical intense expressions, even though we never see them in real life? Is it the wisest choice to show them in a decontextualized way, although we know that in reality, we spontaneously leverage context in order to make sense of emotional information? And is it really wise to show them alongside emotional labels, which we really do not see in real life, and which several studies have shown powerfully shape the way we perceive faces? On a more general level, most of the social cognitive tasks we use, actually all of them in alcohol use disorder, consider participants as mere third-person passive observers. So they look at information on a computer screen. And this really neglects the interactive nature that characterizes the social situations in which those social cognitive judgments take place. And the next speaker will talk about this much more eloquently than me, but this is also a very important issue. And finally, when we talk about measurements, it's really important that we mention psychometrics. Currently, there's hardly any study looking at the psychometric properties of social cognitive tasks in alcohol use disorder, but my guess is that this is a concern of transdiagnostic importance. And one of those important psychometric properties is reliability. So it's the extent to which a test is able to generate scores that really represent participants' true ability and what the test is intended to measure as compared to measurement error. And this is quite important to consider. Indeed, the less reliable our measures, the smaller the correlations we're able to observe between two measures, even though the constructs they measure are in reality really strongly correlated. And so the larger the samples we need in order to be able to detect those links. So this is really a threat from a research perspective. It impedes our ability to investigate, for example, the negative consequences or the potential mechanisms of social cognitive impairments using correlational approaches. But it's not only a problem for research. It's also an absolute prerequisite if we want to be able to use our tasks within clinical contexts. If we want to make yes or no decisions, for example, who needs or who doesn't need a treatment, or has a given individual progressed enough on a social cognitive ability for the treatment to be interrupted, we want to make pretty sure that these decisions are based on individuals' true ability rather than error. And the only way to ensure that is to have measurements that are highly reliable. So in an ideal world, we should be able to get closer to a situation where we all agree on which labels are relevant for our population of interest, very specifically and clearly define the constructs and maybe the sub-constructs these labels refer to, realize that each of these constructs can be assessed using different types of measurements, each of which is relevant and each of which tells something about a different reality. And for each of those reliabilities, have a set of identified tools that are appropriate. And the appropriateness of those tools should be based on pragmatic considerations, but also theoretical and ecological validity and psychometric properties. All right, so I just want to wrap up here. So what is known now is that alcohol use disorder is associated with widespread social cognitive alterations. And we think these alterations are important for incrementing our new psychological models, improving their ability to account for important phenomena in alcohol use disorder, and ultimately improve clinical outcomes. Now, of course, in order to maximize the field's impact, we should aim for a comprehensive understanding of people's difficulties, their individual variations, and also their underlying mechanisms. And we provided some basis to do that. But of course, a lot of work remains to be done. And this work will be greatly facilitated if we manage to improve a bit the way we think about and measure social cognition. And with that, I want to thank you a lot for your attention. I want to acknowledge my colleagues, some of which are here, as well as my supervisor, Pierre Morage. Without all of these people, of course, none of this would have been possible. And this is not just something I say, it's something that is actually true. And I want to thank you for your attention. I'm, of course, available if you have any question. And I want to take the opportunity just for some advertisements. So the lab in which I did my PhD is looking for PhD students. So if you're interested in that line of work, or if you know someone who might be, don't hesitate to get in contact.